Hello there, Andrew Colsky from Therapy BTS. Today we are going to be talking about transcranial magnetic stimulation, or TMS. We have Tom Malone, who's founder of Precision TMS, and he's going to be sharing with us all the information that you want to know about TMS. So Tom, welcome to the show, and thank you for being here.
Thanks for having me. Appreciate it.
Sure. So tell us a little bit about Tom Malone and how did you get into TMS and give us the backstory.
Yeah, I spent most of my career in academic research, neuroscience research. Um, we were studying largely military veterans with traumatic brain injury and PTSD, and that led me to be acquainted with some veterans who had struggled in the past, and when I was telling them about the research I was doing, they were very interested. There was one in particular who actually had a suicide attempt a couple years before I met him, and and about a year or so after I met him, his wife was actually asking about TMS. And at the time, I was studying blast injury and how that can affect the pituitary, and how that can result in hormone deficiency. And those hormone deficiencies can resemble or mimic the symptoms of PTSD. So some of those symptoms, depression, anxiety, insomnia, fatigue, a lot of those things that you associate with depression and PTSD may have a physical cause in the form of, hormone deficiency. So that's kind of where I was focused at the time. We were doing a lot of neuroimaging research. And so I was working on a DoD study at St. Louis University, the School of Medicine there. And so we're doing a lot of neuroimaging and then correlating that with neuropsychological assessments. So they did a full battery, of these, depression, anxiety, PTSD symptoms. And then we were trying to see if we could find objective biomarkers for those in the imaging. So that was kind of my start. And then, when I was approached asking about TMS, at the time, I had to admit it's just, I see in the literature, from time to time, but it wasn't really my area of, my focus. So I reached out to another TBI researcher, and he actually had a TMS unit in his clinic, in his lab, and we all got together and were able to, talk about TMS and if it would be beneficial to this veteran. And he recommended it to the veteran, and we found a place that could do it. He did it, and it helped. And so that's what kind of convinced me that there's something to this technology, and there's not just some gimmick. And yeah, so that kind of got me on the path there. And then later, I was looking at doing a PhD with that advisor, that TBI advisor, and in the course of that, um, we were looking into TMS, and yeah, that's basically after talking to different manufacturers. I was introduced to a local clinic here in St. Louis and ended up buying shares in that company, and that was my introduction to TMS. And then a couple years later, ended up founding Precision TMS. So that's
Great.
how I got into it. Yeah.
All right. Well, I appreciate that. And there's a lot of information in there and a lot of things that I'd like to kind of go back and explore a little bit deeper because I'm sure that the listeners will have the same questions that I have. So the first thing is this particular veteran that you were talking about sounded like, so he was dealing primarily with PTSD. Is that correct?
Yeah, yeah. I think primarily he actually had a pretty extraordinary career. He was in the Army for 25 years. Um, 20 years he was a tier one operator, and he had been through a lot of horrific experiences. And I think a lot of that, haunted him later. And
Mm-hmm.
yeah, he, like a lot of veterans, struggled at a point. And but thankfully, um, he and his wife, I have to give a ton of credit to his wife, um, sought therapies that would be helpful for them. So to help him get past that and to heal. So yeah,
Okay. Fantastic. Well, I'm glad that he found that, and I'm glad that it was helpful for him, and I'm
yeah,
sure many
absolutely.
other veterans as well. So let me clarify also. Then, you and I are talking about TMS, and I mentioned the long name transcranial magnetic stimulation, which sounds a little bit scary, but we didn't define yet for anybody what that really is. So, can you give us the benefit of just a basic explanation of what is TMS? What are we talking about here?
Yeah. So TMS, it stands for Transcranial Magnetic Stimulation. So it's a magnetic field that's produced, and the most common is it's produced with a figure of eight coil. So think of like the infinity sign or an eight, and the magnetic field is produced in the center of that, and it goes like 2 to 3 centimeters deep, uh, past the skull, and then to the brain. And the area that it stimulates is about the size of a quarter.
Mm-hmm.
And so through Faraday's law of inductance, that actually converts from being a magnetic field to a very small, very focused electric current. And you're hitting a particular part of the brain, and we're targeting part of the brain that is known to be underactive in depression. And when you do that, it causes those cortical neurons to depolarize and to fire. And so they're releasing these neurotransmitters. So, you're getting dopamine, serotonin, norepinephrine, and it's also releasing a protein. It's called BDNF. So BDNF is brain-derived neurotrophic factor, and neuroscience, we kind of refer to that as miracle grow for the brain. And so that really works to help form new neural connections and then to support those that are already there. And so I kind of think of it as you're almost jump starting part of the brain there, and by using this magnetic field, it's much more gentle than the old, ECT method. You think about like Jack Nicholson and, One Flew Over the Cuckoo's Nest, and people have that image, they think it's, electroshock therapy, but it's not at all. It's very gentle, it feels kind of like a tapping on your scalp.
Mm-hmm.
And, we end up doing it, typically for depression. It's usually Monday through Friday for 6 weeks for the first 30 sessions. And then we do the final six over a 3 week tapering period. So we'll do three and then two and then one, kind of like weaning off of medication. So, yeah, that's essentially how it works. And we target for depression, it's called the dorsolateral prefrontal cortex. Most commonly, it's the left side, the left DLPFC, and we'll use an excitatory protocol to help increase the neural activity there. And by doing that, you're basically fixing that circuit that's involved with emotional regulation.
Mm-hmm.
And there was a really cool paper out of Stanford about a year, 2 years ago, where they were looking at how TMS can actually reverse the direction of the signal between that DLPFC and part of the brain that they kind of use to identify ideal targets. Is called the subgenual ACC, so the anterior cingulate cortex. And so, in depression, you basically have that signal going the wrong way. And then, with treatments like TMS, you're able to correct that. So you have that signal going in the right direction.
All right. So let me stop you for a second
Yeah.
here and make sure that I get this right. So basically, when you're talking about someone coming in for treatment, what they are going to experience is they're going to sit down in a chair, right? And then they're going to have some sort of a device over their head, almost like a hair dryer you would see in a beauty salon. Is that a fair?
There is a model that looks like that. It's called the Brainsway.
Uh-huh.
So that one is more of a helmet model. What we use, it's a figure of eight. So I don't know, it's smaller. You can actually put it on any part of the brain, and so you can target the specific part that you want to stimulate, or if you want to use inhibitory protocols, you can do that. So based on the frequency and the protocol we use, we can actually increase or decrease neural activity. And but no, there is a Brainsway that has like a helmet, so it's hitting a couple of different targets at the same time. But most places, I think, use the figure of eight approach.
Okay. And so when you talk about a figure eight, is anything actually touching the person or it's just near the person?
Yeah, so it's making contact just to the scalp.
Okay.
Um, yeah, and so you want to make good contact. So as the magnetic field, penetrates the skull, the scalp, um, you're hitting the part of the brain that you want to. And
Hmm.
I think if you're not having good contact, that can actually, you know, be a little less comfortable. So you just want to have good contact there, and it'll feel kind of like somebody's tapping you there.
Hmm. So when a person is in for treatment, um, again, I want to clarify another thing. So there's no needles, there's no medications, there's no invasive things. It's just something that might be kind of resting on their head, the way you're
Yeah,
describing it.
exactly. Yeah.
Yeah. And and so they come in to your clinic, I guess, and you said it's, several days, but how long are they actually there each time they come?
Yeah. So based on the protocol we use, it could be as brief as a 3-minute treatment.
Hmm.
You'll spend a couple minutes, setting them up in the chair, getting them in the right position, getting the coil in position. But yeah, the shortest one is about 3 minutes um, for the excitatory, and then it could be as long as 20. So the field's really advanced. So back in 2008, when it first got FDA approval, the depression protocol took 40 minutes. And then they discovered they could actually reduce the time in between trains from 26 seconds down to 11 seconds. So that
Hmm.
compressed the time from 40 minutes to 20, which is a huge improvement. And then they were able to look at the frequency. So a lot of places will use what's called theta burst. So that's at like 50 hertz instead of 10. And so that compresses it even more. So you're actually getting the same treatment in 3 minutes with that you would with a 20-minute. It's called the DASH protocol.
I
Yeah.
see. So, all right. So, in terms of this technology, and this is obviously not my expertise, but I've certainly read about it. So, depression is one area that I know TMS is used a lot with. Um, I know that there's a newer area where we're working on OCD. So, are there other things that TMS is used for, or is that primarily it right now? Tell us a little bit more about that.
Yeah. So there are currently FDA approvals for depression and OCD. Um, there are some, open label protocols for anxiety, substance use disorder. There's a lot of research going on for like autism, some of the autism symptoms. There's even some, looking at, how we can use this for schizophrenia. Um, I have a colleague in Michigan who's using it for Parkinson's. So
Wow.
yeah, so they're using theta burst up there to help treat Parkinson's, and I can show you a video, pretty remarkable. A person who having a lot of difficulty walking, a lot of issues with their gait, um, basically becoming normal after several sessions of this. So I think the potential for neuromodulation for a variety of psychiatric disorders is increasing over time. So
Wow.
we also there's an FDA approval for peripheral nerve pain. So we've been doing that quite a bit. Um, a lot of people have, some chronic pain. It might be their back, it might be their hip from a car accident, it might be their neck. Um, and so we've actually been trying it out on several of our patients here, who are being treated for depression. So I want to make sure it's actually working, before we go to market and say, hey, come in for, this pain therapy.
Hmm.
But yeah, we've had really good success with that. So I'd say probably 80% or so of the patients that have tried that, it's provided almost near, instant relief. And it's not permanent. I don't want to, say it's, some cure all, but it tends to last for about a week or two. And that pain protocol they recommend for the first couple of months to come in every couple of weeks anyway, and then you can kind of increase the duration after that for maintenance.
I see. Wow. So, okay. So you've described the actual technology as like this figure 8 coil.
Mhm.
And so if someone is coming in for depression treatment versus some other treatment, is it, do you do the same thing or are you doing something different in terms of a different part of the head? What's different between the different maladies?
Yeah, so the most common treatment is using excitatory protocol on the left DLPFC. But if you do inhibitory on the right one, that's also antidepressant. But it seems to, in quite a few patients, help a lot with anxiety, possibly even better than the left side. So, I mean, a lot of times you do the left side, people, their depression and their anxiety improves. Occasionally, you'll get a patient, their depression will improve, but their anxiety could actually get worse. And so, if that happens, we add on the right side to help drive down the anxiety. And so, we want them to have, the best outcome they can. And we're not helping them that much if it's like, okay, we fixed your depression, but now you have anxiety. So, we really try to treat both of those as much as we possibly can. So, and that would be an inhibitory sequence over there. So there's a couple options with that. Normally we'll do 1 hertz, and traditionally they say, 5 hertz and above is going to be excitatory. So we'll do 1 hertz, which is really low. And then there's also the continuous theta burst, which is really interesting because, we do theta burst, intermittent on the left for excitatory, but if you do continuous, it's actually inhibitory. So we'll sometimes do that on the right side, the right dorsolateral prefrontal cortex, and inhibit that area using that technique. And it's much, much faster. So instead of sitting there for 20 minutes, it's like a 40-second train. We normally do 2, so you're like 80 seconds versus 20 minutes. So yeah, it's a much more efficient way to achieve the results you want.
All right. So obviously you have a lot of training in this, and it's not as simple as just coming in and pressing a button and then the patient leaves. You've got to really know your stuff, and you got to know which area of the brain and all the things you're describing. I can imagine took a lot of time to learn.
Yeah, it's you want to verify, all the parameters. You want to make sure everything's correct. You want to make sure your targets are correct. You want to make sure your motor threshold is done correctly. So it is interesting, the technique we use to assess motor threshold for depression is different than the one we do for, say, OCD. So for depression, we're trying to get like a thumb twitch or a finger twitch. And so we'll send like a single pulse to the motor cortex, to the, part of the motor cortex that corresponds to your right hand. We'll usually do the left side, unless there's some other reason to, do the other side. So that's the technique we use for depression. And for OCD though, we're trying to get a tibial response. So like, either their foot will kick a little bit or a toe will twitch. And so to do that, we go to vertex, which is in, the top of your skull, like the middle of the motor strip, and we'll send a single pulse there. And that's generally a significantly higher power level than what it takes to get a finger twitch, because it's a deeper structure to get a tibial response. And that corresponds really well with the target of OCD, which is the medial prefrontal cortex. So it takes, you know, usually it's about 20% more power to achieve that with OCD protocol. Yeah.
Great. Okay. So, can you give me an example of like one of your most successful cases, whether it be depression, whether it be OCD, whatever it may be? I'd love to
Yeah.
just kind of hear a real story.
Yeah. I mean, we had a police officer, retired. He retired because of his PTSD, and he had depression, anxiety. His OCD score was actually quite high, and we started out treating his depression, and that improved, but his anxiety, was still persistent. And so we added on the right side, to help with the anxiety. And he was still having, some PTSD symptoms. And then we looked at his Y-box score, the Yale Brown Obsessive Compulsive Scale, and that was still quite high. And so we added on the medial prefrontal cortex for OCD and drove that down. So he was doing great with that. So um, I wouldn't say we cured his PTSD, but we very effectively treated it, and
Hmm.
so he's doing much better. But that's just that's one example. We've seen a lot of really amazing cases. I mean, there was, I guess I should add that we can treat migraine with this. We'll do inhibitory on the inion, so that little bump on the back of your head. That's one of the landmarks we use, and so we'll do 10 minutes of 1 hertz with that. That seems to work really well with migraine, and I'd be interested to see. I haven't tried it yet with anybody using that continuous theta burst. Since the 1 hertz is inhibitory, instead of sitting there for 10 minutes, could you knock out a migraine in 40 seconds? So that might be an option. But yeah, we had a young lady, um, she was a veteran. She had been through some pretty traumatic experiences, and was scoring very high on, for depression, anxiety, PTSD. And we were able to treat her, and it worked very quickly on her. And yeah, so she's doing great. So um, yeah, and yeah, I'd say the one group that we don't really see a lot of benefit with TMS are people with like borderline personality disorder, and the gold standard for that is going to be like DBT, dialectical behavioral therapy. Um, One of the psychiatrists we work with kind of feels that TMS can kind of help get them to the place where DBT would be effective, but on its own, TMS by itself is not going to be that effective for them. So, but I think it can help them, on that journey, along with DBT to get better. Um, yeah, we've I don't know, there you get some cases that um, we have one patient. She had tried meds for decades, different medications. They might work for a while, then they fail. Um, and she was kind of at the end of her rope. She had tried ECT, and it did not help her much at all. She had memory loss, um, but we do weekly TMS with her, and so that's the one thing that's ever worked for her. So um, we're just doing that, and she's doing great. I mean, she's sunshine when she walks into a room when she's feeling well. I've there's also been times where she might not feel well and she can't come in, so she might miss a week or two, and she crashes. And I've come in on weekends and kind of done kind of emergency TMS with her on those points, and those are some of my best memories, of working in TMS. Just realizing how important this is to people and how beneficial it is, and how effective it can be for people that are really struggling, and who don't really have other alternatives. So
Right.
yeah, those are some of the more memorable cases.
So, I mean, it's great, like when it works, how successful it can be. And I have a colleague of mine actually who told me that she had um, dealt with really severe depression for a long time and tried everything and nothing had worked for her. And she went in for TMS and it was almost this instantaneous change for her. And so, in terms of people thinking of TMS as a cure versus a treatment, what would be most accurate for people to think about it?
Yeah, I'd say it's probably more of a treatment. I mean, we do track our patients for a couple of years after treatment to make sure that they're still doing well. And I'd say 75% of them, they get TMS one time. They're still doing great, 2 years later, a year later. Yeah, and we'll send like the PHQ-9 to them, the GAD-7 for anxiety. So we try to quantify, how they're feeling. I know it's a weird way to say it, but just to track how they're doing, because we don't want them to slide back to where they were. Um, so I'd say, yeah, 3/4 of them, they're still doing great, a couple years after TMS. About a quarter, they'll need some kind of maintenance. That might be a year and a half later, might be 6 months later. Um, so, for them, especially, I'd say it's more of a treatment. So um, they're probably going to need some kind of maintenance. So we try to track them, closely, check in with them, every 2 or 3 months, and then see where they are and see if they need to come back in. So yeah.
Okay. All right, great. So then in terms of, two other questions that I think are important. Number one, when I was first reading about it a couple of years ago, it was being used after all other treatments had not worked, and then TMS was a final stage. So that's one question: is that still the case? And the second question is this something that insurance typically would cover?
Yeah. So I'll answer your second question first. So yes, insurance covers TMS now. They do typically want to see some antidepressant medication failures first before they'll cover it. So it's usually 2 or more med trials, typically from 2 or more different classes of antidepressant medication, and some of them are still wanting uh, talk therapy, to see that you tried that, because that can be really effective too. I think, especially if it's mild depression, um, I think talk therapy can be, really effective. Especially if it's like CBT, um, something that's really evidence based that that has results. Um, and then as far as being a last resort, I don't know if I'd consider it. It's close to that. I mean, so there's TMS. 5 years ago, 2019, there was FDA approval for Spravato, which is intranasal esketamine. And so that's really great for depression as well, for treatment resistant depression. And I don't even like the term treatment resistant, because that just kind of, I don't know, it kind of sucks away hope from people. I think a better term would be like traditional medicine, resistant, the SSRIs and SNRIs and MAOIs and TCAs that are, they've been using for the past 50 years. So Spravato is another tool we have. Then there's also vagus nerve stimulation. So they can actually implant a stimulator connected to your vagus nerve, and that can be, pretty effective. So I'd probably say the VNS is probably more of a last resort now. It's invasive though. There's a lot of times it can make your speech harder to understand. Um, so I think there are some side effects that people would, prefer to avoid if they can with VNS. Whereas, with the Spravato and the TMS, it's much more easily tolerated as far as side effects. The side effects with TMS, usually it's you might have headache, towards the beginning of treatment. There might be some fatigue, might be some, scalp irritation where they have the coil. Those are the typical, side effects with TMS. There's like a 0.1% chance of seizure with TMS. We've never had one. I want to keep it that way. So we're very careful when it comes to, assessing motor threshold. And, medications can affect motor threshold. So, we'll check in at least, halfway through the treatment to see if that motor threshold has changed. And especially if you change your meds, that can affect the motor threshold. So, say day one, we assess you and you're at a 60, but then you change your meds and now your real MT is actually 80. So you're not getting an effective dose at that power level anymore. Whereas, conversely, say you're changing your meds and now your MT's like at a 40, but we, think you're still at a 60. Well, now we're giving you too much, so that could increase the risk of seizure. So it's really important to talk to your doctor and talk to your technician and let them know if you're changing your meds at all, because that can definitely affect your motor threshold and your outcome. Another possible um, side effect with TMS, and I don't know, I've talked to medical directors from other companies, and they don't really think this is a possibility, but serotonin syndrome. So if you have too much serotonin in your synapses, that can lead to you know seizures, a possibility, muscle rigidity, dilated pupils, irritability. There's quite a few negative side effects with serotonin syndrome. It's usually the result of you know messing around with your medications too much. Say you're supposed to be taking, I don't know, 50 milligrams of an SSRI, and now you're taking 500. So if you're doing stuff like that, that could more likely lead to serotonin syndrome. And it's treatable, but the doctor needs to be aware of those symptoms and be on the lookout for that, and the technician as well, and patients too. It's extremely rare, but it's not impossible. I wouldn't say the probability is zero, but yeah, it's extremely rare, and we've never seen it in our clinic, and yeah, I hope to continue that.
Yeah, let's hope you never see
Yeah,
it. So, well, I really appreciate you taking the time to explain all of this to the audience so they can really have a much better understanding now of what TMS is and how it works and what it's used for. And it's come a long way and sounds like it continues to, have more uses and more opportunities. And that's, really great to hear. So, I really want to thank you. So again, this is Tom Malone from Precision TMS. If somebody wanted to get in touch with you, where do you practice and how would they find you?
yeah. So we are in St. Louis, Missouri. We're in one of the suburbs. It's called Creve Coeur, um, which I believe is French for broken heart. So that's a good way to remember it. So we're in St. Louis, Missouri. Our website is precisiontms.org, and our phone number is 314-881-8671. So it's 881 TMS1. And I do want to add too, so another emerging therapy using TMS is for stroke. So we've actually been sent some patients from, uh, a neurosurgery department, some patients that have had stroke. And so we're treating them for, depression, but then also helping with their rehab. So, say they had a stroke on the right hemisphere, and their left hand is not functional. Um, so we target the area that was damaged, and we're actually using theta burst on that, and to help with their recovery there. So we're actually seeing some progress in that patient. So it's kind of miraculous. For the
Oh,
first time this week, they were actually able to click a pen, which they hadn't been able to do for about a year and a half. So
wow.
yeah, so I think
Never heard of it being used for stroke. That's
yeah,
interesting.
yeah. There is so Michael Shugru, he's at Columbia University in New York City now. He's a neurosurgeon. Uh, Interesting guy. He's from Oklahoma originally. He was practicing in Australia, um, and then he started working with this connectomics company. So the next level is actually going to be, the circuit-based therapeutics, MRI-based therapeutics. So we'll be doing, MRIs on patients, and then doing like a connectomic map of their brain, and being able to look at white matter tracks and seeing, what's connected to what's damaged, where do we need to stimulate. And I think that's going to be really, really helpful for stroke recovery. And then also as we expand what we can treat as far as neuropsychiatric disorders. So yeah, I think that's going to be the next wave. Yeah.
Yeah, wow. That's exciting.
Yeah.
We'll have to have you back to give us an update as to what else has been going on. But
Yeah,
it sounds
love
like
to.
your work can be very rewarding for you to see these patients who, you know, were struggling with things and now they're doing better.
It's amazing. It really is. I mean, you see people that are on the verge of, suicidal. I mean, they're having suicidal ideation, and they just, and not a lot of them, they're not actively suicidal where, they're going to do something, but a lot of them were there at the point where if they didn't wake up tomorrow, they wouldn't mind it. And then, to bring them from that deep, deep, severe depression to actually enjoying their life again and being able to get out of bed, being able to take care of themselves and work, like that's hugely rewarding. And I love to see that. And yeah. And, you think about OCD and, I was, you know, reading about, like some celebrities that, have had it. And I think if you can channel it in the right way, it can actually be super rewarding and productive. I mean, one of the celebrities they were talking about was David Beckham, and I'd always kind of suspected because I saw an interview with him, and he just practices penalty kicks relentlessly and such a perfectionist. I mean, the guy's amazing, right? What do they call that movie? Bend It Like Beckham or whatever. Um, the dude's just relentless. He's such a perfectionist. He's so good at that. And then so that was really interesting to me. And then I saw him talking about his refrigerator and like arranging the Diet Cokes in his refrigerator. And he's like, yeah, if there's an uneven number, I'll throw one out. And that to me is kind of like, yeah, maybe. And then, yeah, sure enough, I guess he revealed later that he actually has OCD and he struggles with that. And, I think Justin Timberlake was one. I think Cameron Diaz, was another. And I think, if you can channel it into something and I think it can actually be very helpful, just like ADHD. There's was it Dr. Hallowell? I think he's a Harvard psychiatrist. He kind of talks about how ADHD can be a superpower. He kind of compares it, the analogy he uses is like you have this Ferrari engine but you have bicycle brakes. And so he talks about the positive things you can do with that. So I think a lot of these things that we kind of consider disorders, um, if if we can channel it correctly, I think they can actually be really, really useful.
Mm-hmm.
So anyway,
Yeah,
but
no, I appreciate all of that, and again, like I said, I'm glad that we're finding more and more things that you can treat with TMS, and that you're seeing the results that you're seeing, and it's something that didn't exist before, so it's always good to have additional treatment options out there
yeah,
for folks.
absolutely, absolutely. And thank you again for having me. I really appreciate it.
Yeah, no, no, no. We really appreciate you being here. I appreciate you explaining it all. I'm sure the audience has learned a lot, as have I. And like I said, we'll have to have you back again after we have some more information in the field to share. But thank you for your time.
Good. Anytime. Talk to you later.